Welcome to the Generalist CCFP 105 Topics Podcast. I am Caleb Dusdahl, and this is
Chris Cochrane.
Today we have behavioral problems, and not just because that's today's topic.
Thank you, Caleb. This topic's objectives are rather vague and really don't focus on an age range. So we're going to try and give a nice overview spanning all ages. However, I'm guessing they're more likely to test us on issues related to a toddler or adolescent than, say, someone older, but who knows? So here we go.
Objective 1. In all patients, when working up a behavioral problem, ensure a thorough assessment of medical and mental health conditions and psychosocial factors before offering a diagnosis or definite advice.
The meaning of behavioral issues is somewhat unclear here and will need to be clarified with the patient or their family. The differential is of course rather broad as a result, and we will need to include both medical, social, and psychiatric causes.
For the medical issues, you want to go through your DIMS mnemonic for delirium if it's an acute change, or look for some of the more chronic conditions that can affect behavior. Either way, make sure you've thought about these things like hearing and vision impairment in both the young and the elderly. Think about central causes like head trauma and seizures, metabolic disorders like hypo or hyperthyroid, electrolyte abnormalities or DKA, toxins like lead, carbon monoxide or other ingestions or drugs, anemia, and perinatal or genetic causes. You could also think of neurodegenerative disorders in the right folks in this area too.
Psychosocial factors can play a large role in a presentation of behavioral issues. That can be aberrant behaviors from the patient or unusual expectations or parenting styles, as you'll sometimes find. You should always keep in mind the possibility of child abuse or neglect, as well as issues with housing and food security, substance use, stressful situations, or peer conflict.
Once you explored the possibility of medical or social issues, it's time to hone in on the possibility of psychiatric diagnoses. This is really going to be driven by the presenting complaint as well as the age of the patient. In younger patients, you're going to want to definitely consider autism spectrum disorder, learning disorders, ADHD, oppositional defiant disorder, and conduct disorder.
In adolescents and adults, think more about mood disorders like bipolar and depression, psychotic disorders like schizophrenia, the spectrum of anxiety disorders including generalized anxiety, OCD, PTSD, and eating disorders, as well as self-harm behaviors as a coping strategy, and of course, personality disorders.
Now, by contrast, when we're talking about adults and the elderly, these same conditions that Chris mentioned might be present, but new onset symptoms are more likely related to a neurocognitive disorder, depression, medication causes, or as a result of medical structural causes. And definitely don't forget about personality disorders, but that's the topic for a future episode.
All right, so we're going to take a little road trip away from the objectives. We're going to talk about ADHD, ODD, and CD, which do not have their own CCFP topic, as well as schizophrenia, which is mentioned in the objective, but they really don't talk about it anywhere else. So, ADHD is a common concern in children. Parents can be quite anxious about it, and the patient can be quite affected by it if left untreated. The biggest Canadian guidelines covering this are the CADRA guidelines, that's CADDRA. They're available online and in the show notes. They were just updated last year. In these, they suggest that patients with ADHD can be managed in the primary care setting, but of course, a diagnosis must first be made.
Off the bat, some red flags that can prompt you to consider ADHD in your young patients include
poor organizational skills, be it time management like missed appointments, frequent late and unfinished projects, or erratic work and academic performance.
Also consider if anger control problems or family and marital problems.
Difficulty in maintaining organized household routines, including sleeping patterns and other self-regulating activities, including finances.
Addictions such as substance use, compulsive shopping, sexual addiction, overeating, compulsive exercise, video gaming, or gambling. You definitely want to think about it if the 6-year-old is having compulsive shopping issues.
For sure. Ordering all that stuff on mom's credit card. All right. Frequent accidents, either through recklessness or inattention, are also a red flag.
Problems with driving, such as speeding tickets, serious accidents, or someone who has their license revoked for same.
Having a direct relative who has ADHD.
having to reduce school course load or having difficulty completing assignments at school.
And finally, low self-esteem or chronic underachievement can all be signs to make you think about ADHD.
So more to the diagnosis. According to the DSM-5 and CADRA guidelines, the diagnostic tasks for diagnosing ADHD are to ensure that current symptoms meet the criteria for either inattentive or hyperactive impulsive subtypes, or both, which we'll cover.
That is either 6 of 9 of either of those criteria. We're not going to go over the whole list here. There's obviously 18 criteria. They're in the show notes. They're easily searched online.
Additionally, the age of onset of these symptoms is present by the age of 12.
The symptoms must impair the individual in 2 or more roles, as they call it. So that really means issues with 2 or more of work or school or home, and they have to last for at least 6 months or more.
And as with many of the DSM criteria, you need to have a lack of alternate explanation for the symptoms, such as substances, other mental health issues, and circumstantial conditions that might explain it better.
For sure. The treatment of ADHD includes both environmental changes and medications. Typically, this is long-acting stimulants. The main side effects you should know for these can be anorexia, weight loss, and sometimes impaired sleep. Again, CADRA has complete recommendations for this.
One other condition that was briefly brought up in the objectives heading 2 in this population is schizophrenia. This can present with a prodromal phase of negative or positive symptoms. Often you can see this in the later teen years, and it can last a couple of years prior to the onset of the typical symptoms of schizophrenia. On the negative side of the symptoms, there might be social isolation, decreased emotions, avolition, decreased ideas, and deterioration in social roles. And then things to look for prodromal on the positive side, there could just be unusual thoughts, some paranoia, some grandiosity, or perceptual disturbances. Objective 1. Item B, use a validated assessment tool if available.
This is going to depend on what you're suspecting, but tools for screening and diagnosing ADHD and ASD, or autism spectrum disorder, are standard in their workup. These include things like the SNAP-4 and Vanderbilt scales for ADHD, and the MCHAT or ADIR for ASD. Be aware when using these tools and ensure you're using the appropriate questionnaire, whether that's for screening or diagnosis. Other useful screening tools include the Beck Depression Scale, PHQ-9, GAD-7, and Mood Disorder Questionnaire. The CPS website has a really good page for screening tools that we will link in the show notes.
Use multiple sources of information with consent. This may go without saying, but you will need more than one side to get the full story. This includes talking with the patient alone, if appropriate, as well as with just the caregiver, if the patient is okay with that. Getting information from the teacher or the school, the nursing home, or other community members can be challenging, but this is vital to the diagnosis of a number of conditions that require that the symptoms be present in more than one setting, or where the symptoms are only present in certain situations. The things that come to mind for this are ADHD in the younger patients and sexual disinhibition in the elderly as a result of dementia. Explore the patient's own perspective, not just that of the caregiver.
I think we just mentioned this, but take info from both the patient and their caregiver, ideally separately. You may get very different stories or pick up on other issues.
Too true. Objective 2. In assessing behavioral problems in adolescence, specifically look for substance use, peer issues, abuse, and other stressors.
Just like the objective says, we need to assess each of these domains. Using the HEADS mnemonic is helpful here. That's HEADSS, standing for home, education and employment, activities, drugs and alcohol, safety and sexuality, and suicidality. It's important to emphasize the terms of confidentiality with adolescents. Nothing you discuss will be discussed with their parents without the patient's consent, except if there is suicidality or concerns for safety.
Boom! Objective 3. While assessing behavioral problems in a patient, A. Evaluate the impact of the behavior, B. Explore any underlying emotional distress with the patient, and C. Destigmatize any embarrassing behaviors. Evaluating the impact of the behavior. For this, you will need to explore how the patient feels about their behavior and how those around them feel, or how it subjectively affected their work, school, or relationships. You might remember learning Fife in medical school. This is the point to pull that out.
The next subtopic says to explore any underlying emotional distress with the patient. Continue your fifing and figure out how they feel about the situation. Easy as that.
Fife. Forever. Fife. Destigmatize embarrassing behaviors. Normalization is often key to building rapport, getting a complete history of the behavior, and helping the patient's discomfort or anxiety about the situation. There's not much more to say about this. Objective 4. When making a diagnosis of a behavioral problem in a patient, avoid premature labeling of a behavior as a disorder and follow up with support and regular visits until the situation is clearer and any therapeutic requirements become more evident.
Patients can have some signs or symptoms or traits of a disorder without meeting diagnostic criteria, or you may not have enough information to make that diagnosis, or perhaps referral to a psychiatrist is warranted. In any case, feel free to use language that leaves room for diagnostic uncertainty. You can tell them what their symptoms are often seen in, or perhaps what things you're thinking about but need more information. You don't always have to have a diagnosis.
Close follow-up is useful for these cases regardless of diagnosis being made or what that happens to be. That's it. Objective 5. When assessing behavioral problems, assess and address immediate risk for the patient and others, and do not limit treatment to medication. Address other dimensions and match to available community resources.
Here we need to assess for suicidality. This is ideation, passive or active, whether a plan is present, and whether there's the means to do it. Also take into account preparatory actions like notes or putting affairs in order, and any history of the same. You should also assess risk to others via homicidal ideation with all the same points as with suicidality, as well as possible unintentional risk to others, be it driving while manic or impaired due to drugs or a medical condition, or the presence of small children and inattentive caregivers. These are all things to think about.
Subheading B was not limiting treatment to medications, but ensuring you address other dimensions. The environmental aspects of ADHD treatment have been shown to be very helpful, either alone or in addition to the pharmacologic and medical treatment, and this should be considered first line even prior to a diagnosis. Similarly, cognitive behavioral therapy has shown to be useful in several psychiatric disorders and should be first line or in conjunction with the medication. Objective 6. When there is a challenging relationship with a patient with behavioral problems, maintain a continuous, therapeutic, and non-judgmental relationship with both the patient and their family.
Be sure to begin all patient encounters and relationships with an open mind, being sure not to openly judge patients based on the information they are telling you. Our job is to hear them and help them. We can't do that if our own prejudices are clouding our judgment, or if we're busy telling them how their decisions are a terrible idea. They probably already know that.
Not all patients are forthcoming with information or cooperative with interviews or treatment. Maintaining your professional approach while dealing with patients that are uncooperative, belligerent, angry for one reason or another can be tough. Being aware of how the patient's making you feel is the first step in reacting in an appropriate and constructive manner. Especially if you think back to people you've dealt with personality disorders, it's totally reflected in how you feel. This is the whole transference, counter-transference thing. Overall, this objective touches on one of the hardest challenges that we're going to face in our careers.
But you can do it.
You totally can.
All right, so that was behavioral issues.
It was good. It was fun. It was a little bit of the soft, not the necessarily some of the more objective medical stuff, but just as important as anything else.
Thank you for having me.
Thank you for having me.
Remember to subscribe, leave some feedback, get a hold of us if you want to help out or anything like that.
Totally. We need your help. We want your help. And keep crushing it. Bye.
See ya.